Hi friends, welcome to this module on mitral stenosis and mitral regurgitation. These two topics are considered very important because the most common disease under rheumatic heart disease is your mitral stenosis, and the most common or most likely case you will encounter into your practical exam is also mitral stenosis. Okay, so please pay close attention. We'll first see the normal circulation. What happens during the systole and diastole in a normal circulation? Basically, the atrium receives blood during a atrial diastole, right? Atrial diastole, the atrium receives blood. Then what happens? This blood will come into the left side of the heart, okay, which will be during the ventricular diastole, which will be lasting for 0.5 seconds. Then this blood will be pushed into the aorta, right, during the ventricular systole, which lasts for about 0.3 seconds. So this is the normal circulation, and this is the box diagram of the same. Okay, this box diagram can be used to increase your understanding, because whenever you feel confusing, this diagram confusing, this first diagram confusing, then you can choose this diagram, and whatever hemodynamics you want to learn regarding an ASD or VSD, whatever hemodynamics you want to learn, you can choose a box diagram. Okay, so just a fast revision of what we had seen in the previous module. Systole lasts for 0.3 seconds and it consists of isovolumetric contraction and ejection phase. Diastole lasts for 0.5 seconds, which consists of isovolumetric relaxation, rapid inflow, diastasis and atrial systole. Okay, and this is the same picture which we discussed in the previous module. First is your AV valve closure. Atrioventricular valve is nothing but your mitral and tricuspid valve, which produces your S1. Okay, S1. And after this, there will be a isovolumetric contraction phase, during which the volume in the ventricle remains the same, but the pressure increases. Then comes the ejection phase. After the blood gets ejected, and when the aorta's blood pressure, okay, becomes more than the ventricle blood pressure, then the valve will close. Aortic valve will close. Then comes the isovolumetric relaxation, that is the volume in the ventricle remains the same, but the ventricle is relaxing. Okay. Then comes the rapid inflow phase. How the rapid inflow starts? There the atrioventricular valve, that is your mitral and tricuspid valve, will open. Then comes the rapid inflow, then the diastasis, then the filling, which is contributed by the atrial systole. Okay. Before going further into the mitral stenosis and mitral regurgitation, I would like to discuss about mitral valve apparatus. Why is it important? Mitral valve apparatus, anywhere in the apparatus when there is a problem, it can lead to manifestations of mitral regurgitation, sometimes mitral stenosis as well. Okay, so what are the constituents of mitral valve apparatus? Yes, it is, number one is leaflet. Okay, so this is a leaflet, this is a antemitral leaflet, postmitral leaflet, and commissures. These ends are called as commissures. Okay, then mitral annulus, the ring-like structure surrounding this is your annulus. Next comes the chordae tendineae, next comes the papillary muscle. Chordae tendineae, these cord-like structures are chordae tendineae and the papillary muscle, and the ventricle also may be included as a part of mitral valve apparatus. If there is a fusion here, okay, the chordae tendineae is fusing, then it can produce a narrowing of the mitral leaflet. Okay, if the mitral leaflet is getting calcified, that can also produce narrowing. Okay, if there is rupture of the chordae tendineae, that can lead to your mitral valve regurgitation. And if there is any papillary muscle rupture, especially which can happen in a myocardial infarction, there can be mitral valve regurgitation. Okay, so this is the slide which I had depicted to tell you the hemodynamics, what exactly is happening. So there is valvular narrowing in this area. The mitral valve is getting narrowed. So what happens is large amount of blood is staying in the left atrium. Okay, so that will lead to left atrial volume overload. Okay, left atrial volume overload, and this will be conveyed to the pulmonary veins. Okay, so that causes the pulmonary venous congestion. Okay, this is a pulmonary vein, it's pulmonary venous congestion, and that will be transferred to your pulmonary artery, and that causes the pulmonary artery hypertension. Then the right ventricle will become hypertrophied. Right ventricle will pump against resistance, and then the right atrium will also enlarge. Okay, so this is the sequence. First, what happens is the right stenosis will lead to left atrial volume overload. Then comes the pulmonary venous congestion, then the pulmonary arterial hypertension, then the right ventricular hypertrophy, then the right atrial enlargement. Okay, when there is failure, that will lead to your right heart failure features. Okay, so what are the classical sounds which we can hear in this mitral stenosis? S1 is loud, then after the S2 there will be a opening snap, then comes the mid-diastolic murmur with the pre-systolic accentuation, then comes the S1 again. Okay, so how will we check for the murmur? Roll the patient towards the left lateral posture and then you'll check for the murmur. Alright. So what are the causes of mitral stenosis? So first most important cause is your rheumatic fever and the rheumatic heart disease. Okay. Then comes your congenital, that is parachute valve or cor triatriatum. Okay. Then mitral annular calcification with leaflet involvement, SLE or rheumatoid arthritis. Okay. Myxomas or drugs like methysergide. Okay. And carcinoid syndrome. These are the common causes. Sometimes infective endocarditis with large vegetation can also lead to a mitral stenosis. Okay. The most important cause in India, okay, is your rheumatic fever leading to rheumatic heart disease. Okay, mitral stenosis in India, any patient even without history of rheumatic fever, you can consider that it is probably a rheumatic etiology. Okay, symptoms of mitral stenosis. So what are the symptoms of mitral stenosis? There will be a latent period. You should remember that the rheumatic fever, okay, occurs between 5 to 15 years, whereas the manifestation will take around 2 decades. Okay, and mild mitral stenosis, there will not be any manifestation. And if there is, hyperdynamic circulation states like an anemia or thyrotoxicosis, then the patient will manifest with symptoms. Okay, what are the symptoms? Can be dyspnea and cough, orthopnea, PND, hemoptysis because of the rupture of bronchial venous connections, secondary to pulmonary venous hypertension. Recurrent pulmonary emboli can happen and winter bronchitis can happen. Okay, during winter season, the patient will be prone to get recurrent episodes of bronchitis or bronchopneumonia or lobar pneumonia. And when there is right ventricle failure as well, okay, I discussed already, there is left atrial enlargement, left atrial volume overload, pulmonary venous congestion, then the pulmonary artery hypertension, then comes your right ventricle, failure, right ventricular enlargement, hypertrophy and failure. Okay, so that condition will lead to edema and ascites. Alright. So how will you say that it is a case of mitral stenosis? So this will be the question. As soon as you finish examination, you go to an examiner. The examiner will be asking this question. Sometimes they will go retrospectively, sometimes they will go from the beginning. Okay, sometimes they will ask you to present from general examination, tell all the positive findings you had in this case. Sometimes if you are going last, what they will tell is, you tell the diagnosis, tell why you are saying that it is mitral stenosis. So if the question is asked, you have to start from the beginning. Okay, from the general examination, is there any finding? Is there any mitral feces? Look for that. Okay, cyanotic cholangiotasia, you can look for that. Okay, then JVP, check for JVP. JVP mostly no finding, no significant finding will be there. Sometimes there can be an absent A wave if the patient is having atrial fibrillation. Sometimes there can be a prominent A wave because of a pulmonary hypertension. Okay, these are the 2 findings which you can see in a patient with mitral stenosis. Okay, then vital signs, you have a small volume pulse because the output is affected because of the narrowed mitral valve. Okay, from the mitral valve, the ventricle will receive blood and from the ventricle, the output will be there. So, in a mitral stenosis patient, the volume of the pulse will be narrow. Then, on inspection, any specific findings? Nothing great. Palpation, there can be left parasternal heave, either because of a right ventricular hypertrophy or because of left atrial enlargement. And then tapping apical impulse. This is the classic apical impulse which can happen only with mitral stenosis. Okay. Heaving apical impulse, lot of causes are there. Hyperdynamic apical impulse, lot of causes are there. But tapping apical impulse or tapping apex beat classically happens in mitral stenosis. Okay. Then there can be diastolic thrill, depends upon the severity over the mitral area. Okay. Anything else left? If there is pulmonary hypertension, what happens? There will be a palpable P2. Okay. Palpable P2. Auscultation. What are the classical findings which we hear in auscultation in a patient with mitral stenosis? Yes. Loud S1. Can the S1 be variable? Yes or no? Yes. In your patient, if the patient is having atrial fibrillation, then the S1 can be variable. Okay. Then comes the opening snap. Okay. So loud S1. Then comes the S2 followed by opening snap. Right. Then comes your low pitched, rough, rumbling, mid-diastolic murmur with pre-systolic accentuation is best heard over the apex with the bell of the stethoscope in the left lateral portion in expiration. So these are the characteristic points which you should tell in a patient with mitral stenosis. Okay. So mid-diastolic murmur. Sometimes the examiner may ask, like you have to show, you have to draw how the murmur will be. Okay. So in that case, you have to draw like this. Loud S1. Then your S2 comes, then your opening snap, okay, then again S1, so opening snap, then comes your mid-diastolic murmur, okay, then towards the starting of the systole there will be increase in intensity of the murmur, okay, that is called your pre-systolic accentuation. This pre-systolic accentuation is contributed by your your atrial contraction. So in a patient with atrial fibrillation, this pre-systolic accentuation will be absent. Okay. What are the causes of non-palpable apex beat? This is an interesting question which I didn't discuss in your examination. This many examiners love to ask this question. Okay, you are checking for the apex beat, but you are not able to palpate it. Is that possible? Yes, in a lot of patients it is possible. One, the apex beat in apex is hitting behind the rib. Okay, or a patient with pericardial effusion or a pleural effusion, especially left side pleural effusion, or when there is thickened pleura or pneumothorax, left side pneumothorax. In a patient with emphysema or obesity with thick chest wall. These are common conditions where you cannot palpate an apex beat. Okay. Is there any other condition which is important to be remembered? Yes, sometimes the heart can be in the right side. It is called as dextrocardia. Okay, so dextrocardia can also be one of the reasons for non-palpable apex beat. First you palpate the apex in the normal cardiac examination position, like in 30-degree angulation, reclined position. In the supine only. Then if you are not able to palpate, then you can ask them to turn to the left side. Then you can try for palpating. Even by turning to left side, you are not able to palpate. Then you can comment that it is a non-palpable apex beat. Okay. So why there is mid-diastolic murmur in mitral stenosis? What are the causes? There is only one cause. There is some phase of isovolumetric relaxation phase. We already saw in the diagram, right? The diagram from Guyton. Okay, so there will be a isovolumetric relaxation phase, then only the valve can open and the murmur can come. Okay, so basically the isovolumetric relaxation phase comes, then the blood flow from the atrium to the ventricle starts after the valve is getting opened. The valve opens with the sound called opening snap, and that opening snap can be absent in a patient with calcified valve. Okay, remember that. Okay, only when the valve is getting opened, the murmur can occur, because only when the valve is open, the blood flow from the left atrium to the left ventricle will be there. So that will produce the mid-diastolic murmur. Okay, so what is the name murmur associated with mitral stenosis? It is called as Graham-Steele murmur. It is not directly related to the mitral stenosis, but in mitral stenosis patient, as I discussed already, they are prone to develop pulmonary hypertension. So dilatation of the pulmonary valve ring will lead to pulmonary regurgitation. That murmur is called as Graham-Steele murmur. So how will that murmur be? High-pitched diastolic decrescendo blowing murmur heard along the left sternal border. Okay, high-pitched diastolic decrescendo blowing murmur heard along the left sternal border. So this will be a differential diagnosis for your aortic regurgitation murmur as well. Okay, so aortic regurgitation murmur characteristically we heard in your third left intercostal space close to the sternum, which is also called as Erb's area. Okay. Now tell me, what is Carvalho's sign? In severe pulmonary hypertension, there will be functional tricuspid regurgitation. Yes or no? Because the right ventricle is able to push the blood freely only when there is normal pressure in the pulmonary artery, right? So the right ventricle is pumping, but there is pulmonary hypertension. So instead of the blood going into the pulmonary artery, the blood is regurgitating into the right atrium. So that is functional tricuspid regurgitation. The valve is normal, but since because of the increased volume which is not able to go into the pulmonary artery, it is getting regurgitated into the right atrium. Okay, that functional TR will lead to a pan-systolic murmur along the lower left sternal border, which increases in intensity with inspiration. That is classically called as Carvalho's sign. Carvalho's sign is a functional TR murmur which is heard in pulmonary hypertension in a patient with mitral stenosis. Okay. So differential diagnosis of mid-diastolic murmur. What are the differences? Very favorite question for examiners. Okay. Number one, it is Carey-Coombs murmur. Where do you get Carey-Coombs murmur? This Carey-Coombs murmur can be heard in acute rheumatic fever. Acute rheumatic fever, in that acute rheumatic valvulitis. There will be edema of the valve which will lead to your mid-diastolic murmur. Okay. Then Austin-Flint murmur, which can be heard in severe AR, severe aortic regurgitation. Okay, then functional mid-diastolic murmur, there are a lot of conditions. Okay, so when there is increased flow through the mitral valve, that can lead to your functional mid-diastolic murmur, classically be seen in your ASD, VSD and PDA. Okay, in VSD and PDA it is heard in the same mitral area, whereas in ASD it will be heard in the tricuspid area or the left lower sternal border. Okay. Then comes the left atrial myxoma, similar to the mitral stenosis, it can produce an obstruction to the mitral valve. Tricuspid stenosis, yes, it can produce a mid-diastolic murmur in the lower left sternal area, in the tricuspid area. Ball valve thrombus also can cause. Cor triatriatum is a membrane in the left atrium which can lead to the murmur. Okay. So differential diagnosis, how to differentiate whether this is mitral stenosis, MDM or some other diagnosis. So mitral regurgitation, what happens in mitral regurgitation? Can there be a MDM? Yes, in severe mitral regurgitation. Okay, mitral regurgitation, when it is severe, can be suggested by a mid-diastolic flow murmur. Okay, so normally in mitral regurgitation, the classical murmur is pan-systolic murmur. When the ventricle is contracting, okay, the blood should go through the aorta only, but here the valve is leaking. So what happens is the blood will enter into the left atrium also. Okay, that causes the pan-systolic murmur. But the large amount of blood which is entering into the left atrium will come again into the left ventricle during the diastole. Okay, large amount of blood coming through a orifice will lead to a turbulence that can produce your murmur. Okay, that is your mid-diastolic murmur. So in that case, the S1 will be soft and LV enlargement can be seen. In mitral stenosis, the apex beat will go just laterally, okay, not down and out, just laterally, because it is the RV hypertrophy which pushes the apex laterally. Whereas in mitral regurgitation, large amount of blood will be there, okay, which pushes the ventricle down and out. Okay, there will be eccentric hypertrophy of the ventricle that will lead to down and out apex beat. Okay, and in severe MR, there will be Austin Flint murmur which can be detected by using vasodilators. So the leaking, okay, or the regurgitant blood which is seen in aortic regurgitation, the blood which is pumped forward is coming backward into the left ventricle. Okay, that is also contributed by your peripheral vascular resistance. Okay, so if you give a peripheral vasodilator drug, then the murmur will become softer. Okay, then the tricuspid stenosis, this diastolic murmur will be heard in the increases with the inspiration, and there can be delayed wide descent in your JVP. Okay, so these are the points which can suggest your tricuspid stenosis. In ASD, the classical finding is fixed splitting of S2, fixed wide splitting of S2. In atrial myxoma, there will be systemic features like chronic weight loss or anemia, fever. Okay, due to this serum IgG and interleukin 6 concentrations. Okay, so the atrial myxoma, these are the constitutional symptoms which you can tell that this patient can have a atrial myxoma. By this you can differentiate. And the tumor plop. Okay, tumor plop. Okay, and the position variation can be there in the tumor plop. Okay, so why there is pre-systolic accentuation in the mitral stenosis? What is the reason? Yes, it is contributed by the atrial contraction. Normally the filling, what happens? 80% of the blood will be filled into the left ventricle through passive filling only. Okay, during the early rapid filling, then the diastasis phase, around 80% of the blood from the left atrium to the left ventricle will come. But here in mitral stenosis, what happens is not that much blood will be able to come, and only when the atrium contracts, the rest of the blood will come. Okay, that will produce an increase in intensity in the existing murmur. The existing murmur is mid-diastolic murmur, which increases in intensity because of the atrial contraction. That is called your pre-systolic accentuation. Okay, so what are the signs of pulmonary hypertension? Yes, number one, palpation, palpable P2 will be there. Okay, and of course JVP, there will be prominent A wave. Prominent A wave. Okay, prominent A wave can also happen in tricuspid stenosis also. Okay, in pulmonary stenosis also. Okay, then auscultation, there can be loud P2. Okay, in palpation I told palpable P2, in auscultation loud P2, narrow A2 P2 split, sometimes single S2 only will be heard. Okay, and ejection systolic murmur can be heard over the pulmonary area. Okay, and pan systolic murmur which can be heard in the left lower sternal border, which increases in intensity with inspiration. That I told already, this is Carvalho sign. This is because of functional tricuspid regurgitation. Okay, yes. So why loud S1 in mitral stenosis? There are a lot of reasons which we discussed in the previous module. Okay, door closing is an example. Okay, if you wide open the door and close it, it will produce a loud noise. Whereas if you narrowly open the door and close, then it will produce a small noise, right? The same mechanism can happen here. Here basically the hallmark feature of your mitral stenosis is increased left atrial left ventricle pressure gradient. Okay, this lead to wide open mitral valve during diastole. Also the filling will also be partial, the ventricle is not fully filled. Okay, and that will lead to wide opening of your valve, and abrupt closure of the widely open leaflets will lead to your loud S1. So what happens to the apex beat in mitral stenosis and mitral regurgitation? Okay, so what happens to the apex beat? In mitral stenosis, I discussed already, it is the left atrium which will enlarge, and that will lead to right ventricular hypertrophy that will push the apex just laterally. Isolated mitral stenosis, the apex moves outward in the same intercostal space. Whereas with the mitral regurgitation, the apex will be moving down and out because there will be eccentric hypertrophy. Whenever there is hypodynamic circulation, there will be eccentric hypertrophy, and that will lead to movement of the apex beat down and out. Okay. So what are the causes of loud versus soft S1? Okay. I hope you had you are recollecting the points which we had discussed in the previous module regarding the factors which influence the S1. Okay, so Stenosis valves, okay, the mitral stenosis and tricuspid stenosis, sinus tachycardia, hyperkinetic circulation, short PR interval, normally in children also. Okay, so whenever there is hyperkinetic circulation, tachycardia or short PR interval, the atrium and ventricle will, there will not be adequate gap between the atrial contraction and the ventricular contraction. Okay, normally the valve will be in semi-closed position at the onset of the ventricular contraction, but here there will not be adequate time for the valve to open and then come back to the semi-closed position. So that will lead to your loud S1. Okay, and the diastole gets shortened in your tachycardia, right? So there will not be proper filling of the ventricle. So there will be wide opening of the valves which closes suddenly, that will produce your loud S1. Okay. So soft S1, mitral regurgitation or tricuspid regurgitation. So where there is no proper coaptation of valve. I discussed already coaptation. That means the fusion of the valve leaflet. Okay. So that will not happen. So that will lead to your soft S1. Prolonged PR interval, right or left ventricular dysfunction. Yes, the proper contractility of the ventricle is necessary for producing a proper heart sound. Okay, and calcified mitral or tricuspid valve can also lead to your soft S1. Obesity, emphysema, thick chest, pericardial effusion. So these conditions we discussed in the non-palpable apex beat, right? So the same conditions can also cause a soft S1. Okay. So how will you clinically assess the severity of mitral stenosis? There are 2 points, very important points you should be thoroughly telling your exam. As soon as this question is, you should be anticipating this question. Okay, when you are presenting this case, this question will always be asked. So there are 2 factors. One is your S2 OS gap, that is the gap between the S2, that is the second heart sound, and the opening snap. This will be inversely proportional to the severity. Okay, so the smaller the gap, the more severe is the mitral stenosis. That is first most important point. The second most important point, the duration of the mid-diastolic murmur is directly proportional to the severity. So the longer the duration of the mid-diastolic murmur, the severe is the mitral stenosis. Okay, this diagram will tell you. So this is mild mitral stenosis. The murmur is less, okay, less duration, and the gap here is more. Okay, whereas here severe mitral stenosis, the gap is less and the murmur is long duration. Okay, long drawn murmur. Okay, so longer duration of murmur tells that it is a severe mitral stenosis. Okay, so how will you assess the severity by echo? How will you assess the severity? Basically based on the valve area. Normally it is 4 to 6 centimeter square. Less than 2.5 to 2 centimeter it is your mild mitral stenosis. 1.5 to 2 it is your moderate mitral stenosis, and 1 to 1.5 is severe, and less than 1 is this very severe mitral stenosis. It may be also called as critical mitral stenosis. Okay. How will you clinically say that the valve leaflets are palpable? The most important sound which tells that the valve leaflets are palpable is your opening snap. Okay. Sometimes the S1 itself will tell that the valve is palpable, because the valve, only if it is pliable, opening and closing properly, then only the heart sound will be generated. Right. So the most important thing is your opening snap. Okay. The presence of opening snap tells that the valve is pliable. Okay. So why are we telling about this pliability of the valves again and again? Why? Because if the valve is pliable, then we can do an intervention called balloon mitral valvotomy. Okay. Otherwise, you have to go for replacing the valve. Okay. Either a prosthetic or your bioprosthetic or your metallic valve. Whereas if the valve is pliable, then we can go for a balloon mitral valvotomy. If the opening snap is heard in the mitral stenosis patient, what does it convey? So once again, the same question in another format. Valve leaflets are pliable. Okay, opening snap is equal to pliable valve leaflets. Right. And one more important point is your mitral stenosis is organic. Okay. Thrill in a patient will tell that it is organic. It is the valve pathology. Similarly, your opening snap will tell that the mitral stenosis is organic. Okay. And this is another point I told already, amenable to be valvotomy. Okay. So what are the other causes of opening snap? Is there any other cause? Yes, even tricuspid stenosis can cause your opening snap, right? It is the same, ditto. From the left side, if it happens, it is your mitral stenosis, it is opening snap. Right side, it is your tricuspid stenosis. Even ASD, VSD and PDA, these hyperdynamic circulatory states can also cause your opening snap. Okay. So how will you differentiate between opening snap and S2 split? Opening snap happens during diastole. The S2 split, A2 and P2 will happen, like it is a second heart sound basically. That will also be closely mimicking your opening snap. So how to differentiate? Ask the patient to stand. That is the most important maneuver you are going to do. Ask the patient to stand. Okay. So venous return to the heart decreases. An amount of blood entering the right atrium decreases. Left atrium, left ventricle pressure gradient decreases. So delayed opening of mitral valve. So S2 OS gap increases. Understood? Venous return decreases. So amount of blood entering the right atrium decreases. So left atrium, left ventricle pressure gradient decreases. Okay, the pressure gradient increases, especially in severe mitral stenosis, there will be narrow A2OS. Whereas here the pressure gradient decreases, so there will be delayed opening of mitral valve and S2OS gap increases. Okay. Whereas in a patient with S2 split, the venous return to the heart decreases, amount of blood entering the right ventricle is less, pulmonary valve closes early, and so A2P2 gap narrows. Okay, when there is narrowing, then it is probably an S2 split. When there is an increasing gap, S2OS gap increases, so that suggests it's an opening snap. What is Lutembacher syndrome? It is atrial septal defect plus rheumatic mitral stenosis. Okay. So congenital ASD with your acquired rheumatic mitral stenosis is called as Lutembacher syndrome. Which chamber fails first in mitral stenosis? Very, very important and very, very interesting question. Very, very easy question as well. This mitral valve, where is it? Basically it is situated between your left atrium and left ventricle. Okay. Right atrium, right ventricle, there is your tricuspid valve. So when this valve is not opening properly, what happens is this chamber enlarges. Okay, so this is the first chamber to fail in a patient with mitral stenosis. Okay, and the last chamber to fail is your left ventricle. Okay, the first chamber to fail is your left atrium. Okay, right. What is tight mitral stenosis? Tight mitral stenosis, it is severe, or I mean very severe actually. Very severe, tight or critical is less than 1 centimeter square. Okay, normal mitral valve orifice is 4 to 6 centimeter square. Okay, what is silent or damped mitral stenosis? Pulmonary hypertension diminishes the cardiac output. Yes or no? How? The right ventricle is the one which receives all the peripheral blood, right? Through the IVC and SVC, the blood is received into the right atrium and to the right ventricle. This right ventricular blood has to pass through the pulmonary artery into the pulmonary vein, then it should come to the left atrium. Whereas in a patient with pulmonary hypertension, what happens is this blood will not be, the proper quantity of blood will not be able to come to the left side of the heart. So what happens is the murmur intensity can decrease. Okay, so this can lead to a temporary symptom-free period also, because usually what happens is a lot of blood will be there in the pulmonary circulation, a lot of congestion will be there. Pulmonary venous congestion will be there. But when there is onset of pulmonary hypertension, the amount of blood entering into the vein will decrease. So that can lead to a temporary symptom-free period. Okay, and this mid-diastolic murmur may not be audible properly. Okay, so that is called your silent or damped AMS. One another mechanism which is explained for this is, as the right ventricle enlarges, it pushes the apex and it changes the position of the heart. So that will also can lead to your non-audible mitral stenosis murmur, that is a non-audible mid-diastolic murmur. So what are the complications of mitral stenosis? What are the complications? A lot of complications, very important complications are there. Let's discuss one by one. First is a hemoptysis because of your pulmonary venous hypertension and pulmonary apoplexy. Okay, thin-walled dilated bronchopulmonary veins, rupture. Then comes your recurrent pulmonary infections, as discussed already, it's winter bronchitis, especially during winter. And pulmonary and alveolar capillary fibrosis can occur that will lead to hypoxia. And atrial fibrillation can occur in 2/3 of patients with MS, and it is more common in MS than in MR. That is, your mitral stenosis patients most commonly can have atrial fibrillation. It is very common in mitral stenosis than in mitral regurgitation, because mitral stenosis produces an enlarged left atrium, a very giant left atrium. Okay, so the conduction will be affected, and that will lead to your manifestation of atrial fibrillation. Infective endocarditis can occur. Pressure symptoms include Ortner syndrome. Ortner syndrome is nothing but your left atrium enlarges, that compresses the recurrent laryngeal nerve, that will lead to hoarseness of voice. Okay, that is called as Ortner syndrome. Pressure on the left main bronchus can lead to your bronchiectasis. Okay, left main bronchus because of the enlarged left atrium. Okay, that can cause bronchiectasis, like unilateral bronchiectasis can occur. And RV failure can lead to edema, ascites, pleural effusion, hepatomegaly. Okay, when the your mitral stenosis is going on for longer duration, the RV starts to fail, and that will manifest with these manifestations. Okay. What are the non-cardiac symptoms associated with cardiac? This is just general question. Okay, in the history, you are supposed to ask these questions. At least in the past history, you have to check for whether this history is there in this patient or not. Very, very important points. Number one is central nervous system history, basically stroke due to cerebral embolism or endocarditis or hypertension. Why stroke? Okay, in atrial, your mitral stenosis, what happens is there is possibility of thrombus formation in the leaflets. That is one point. If the patient with mitral stenosis is going for atrial fibrillation, then there is possibility that there is a clot can form in the left atrial appendage. That can also embolize, leading to stroke. So what we do is we give warfarin for this patient, and INR target for this patient will be between 2 to 3. Okay, those patients whose valves are not replaced, we'll give warfarin, maintain INR between 2 to 3. What are the gastrointestinal manifestations? Can be jaundice because of the right ventricle failure, or abdomen pain due to liver congestion, secondary to heart failure, or mesenteric embolism. Okay, right. Then renal manifestation include oliguria or nocturia. Oliguria because of the heart failure. There is no forward output, so that will lead to your decrease in renal perfusion, and that will lead to decrease in GFR and decrease in urine output. That is the mechanism for your oliguria. Nocturia because when the patient lies down, all the blood in your interstitial space, okay, all the fluid in the interstitial space will come back into the central circulation, and that will lead to increase in your renal perfusion during night time when the patient lies down, and that will lead to your nocturia, increase in frequency of urination during night time. So what are the ECG manifestations? So coming to ECG, it is a big topic. Okay, I have dealt with in a separate video, okay, in a separate module. Okay, you can check this link in YouTube, ECG Basics NEET-PG Foundation in YouTube. You can find my video there. You can check, you can understand what are the basic things about ECG. But to highlight the important things as pertaining to your mitral stenosis, 2 points to be remembered. One, the mitral stenosis will lead to left atrial enlargement. We discussed already, left atrial failure can happen, left atrial enlargement can happen. The first chamber to fail is your left atrium. Alright, so the left atrium will lead to a tall P wave. Left atrial enlargement will lead to a tall P wave. Okay, sorry, left atrial enlargement will lead to a broad P wave. Okay, whereas right atrial enlargement will lead to a tall P wave. So how to remember this? Okay, suddenly like I got confused, right? So how to remember this? Very easy. Right atrium will enlarge especially in patients with pulmonary hypertension. Yes or no? Yes or no? So this P is for P pulmonale. Okay, P pulmonale. P pulmonale. The P is tall or broad. Tall, right? So that happens in patients with pulmonary hypertension, leading to your right atrial enlargement. Okay, whereas the tall, broad P wave will happen in mitral stenosis because of the left atrial enlargement. That is called as P mitral. M is broad. Yes or no? Compare M and P. Which is tall, which is thin and tall, which is your broad. M is broad, whereas P is tall, right? So broad P waves suggest your left atrial enlargement, whereas tall P waves suggest your right atrial enlargement. Normally in lead 2 there will be positive waveform will be there, and in right atrial enlargement this will become more positive, taller wave. Okay, whereas in left atrial enlargement this becomes more broad. Okay, so these are the points to be known as an undergraduate: tall P wave and broad P wave. Broad P wave is also called as P mitral, which happens in mitral stenosis. Mitral stenosis leading to left atrial enlargement, leading to P mitral. Okay, P mitral. Understood? I'll draw and show you in a separate screen. Okay, so normally the P wave should be like this. Okay, P followed by QRS. Whereas here what happens is, in mitral stenosis, the first chamber to enlarge is left atrium. Okay, remember, even tall P wave can also happen in mitral stenosis patient because they can also lead to pulmonary hypertension, RV enlargement, and RA enlargement. Okay, so but the initial stages what happens is mitral stenosis will lead to left atrial enlargement. Okay, that will lead to P mitral, which will become like this. Normal P become like this. Okay, M for mitral. Okay, it is broad P wave which happens in left atrial enlargement. Whereas if the P wave becomes like this, okay, it's tall P wave which happens in your, it is also called as P pulmonale. P pulmonale which happens in your pulmonary artery hypertension. Okay, pulmonary artery hypertension, right ventricular hypertrophy, and that will lead to right atrial enlargement. Okay, pulmonary artery hypertension leading to right ventricular hypertrophy, leading to right atrial enlargement. Okay, understood? Yes. So what are the X-ray findings? Number one is your straightening of the left heart border of the cardiac silhouette, then prominence of main pulmonary arteries, dilatation of the upper lobe veins, posterior displacement of esophagus by the enlarged left atrium, double cardiac shadow, and curly B lines. Okay, from the distension of interlobular septae and lymphatics when the resting left atrial pressure exceeds 20 mm of mercury. We will see one by one. So see in this, there is a straightening of the left border. Yes, it is very straightened. Okay, and prominent pulmonary arteries will be there, and then this shows a double shadow within shadow or double shadow. Okay, because of the enlarged right atrium and the left atrium. Left atrium is here and the right atrium is here, so that will cause a shadow within shadow appearance. Okay, so see left atrium, this is the right atrium. Okay, this picture is showing a valve replaced patient already. Okay, understood? Yes. So coming to the treatment, how will you treat the patient? Very important is penicillin prophylaxis, because this patient has developed a rheumatic heart disease because of the rheumatic fever. So he is prone to get another episode of rheumatic fever. Okay, a patient with rheumatic fever already has got rheumatic fever, and rheumatic heart disease is almost double the time more prone to get rheumatic fever again. So very important is penicillin prophylaxis. Okay, the duration we will discuss in the next module. And restriction of sodium intake, okay, to avoid the congestion. Oral diuretics can be given, and beta blocker. Beta blocker, what it does is it decreases the heart rate so that it increases the time for the filling of the left ventricle. Okay, so the left atrium to the left ventricle filling time is increased because of the beta blocker, because it decreases the heart rate. Okay, and finally atrial fibrillation, if it is there, we have to treat the atrial fibrillation. Okay, and treatment of the valve, there are two options. One is your percutaneous mitral balloon valvotomy, and this is your surgical valve replacement. Okay, if a valve is amenable to balloon valvotomy, then balloon valvotomy does a good job. Okay, so how will you do that? You will insert a catheter through your femoral vein. You will go through the inferior vena cava into the right atrium. Then you will puncture the septum and go into the left atrium. Okay, left atrium will go. Then you will enter between the valve. Okay, you will insert the catheter into the valve. Then you will dilate the balloon. Okay, and the valve will open. Then you will take off. Okay, this is called percutaneous mitral balloon valvotomy. Okay, so the indications are symptomatic for patients with mitral stenosis, severe MS, isolated severe MS. The very important point is isolated severe MS. If there is moderate MR, okay, sometimes mild MR is also allowed. No, or mild MR is also allowed. Whereas if the patient is already having moderate MR, then it is of no use. Okay, it will damage the valve and it will worsen the MR. So in that case, you are supposed to do only valve replacement. So these are the points which are the indications for your mitral balloon valvotomy. So favorable valve morphology should be there. There is a score called Wilkins score. Okay, Wilkins score for knowing whether the patient's valve is amenable to valvotomy or not. And there should not be any clot, LA clot, because that can embolize the clot, then it will lead to stroke. Okay, so these are the very important points. Okay, very important indications for a patient to be taken for mitral balloon valvotomy. Okay, and these ideal patients are those who don't have a calcium in the commissures. Okay, and successful valvotomy is by 50% reduction in the mean valve gradient or doubling of the mitral valve area. And it is the treatment of choice if a patient is pregnant and refractory to medical management. Any pregnancy patients can tolerate a stenotic lesion. With mitral stenosis, they can tolerate. Okay, sometimes what happens is they'll go into failure. Okay, so in that case, what we'll try is we'll give drugs and control the failure. If the patient's mitral stenosis symptoms are refractory to your drug management, then you can go ahead for a percutaneous mitral balloon valvotomy. It is the treatment of choice for your pregnancy lady with mitral stenosis. Sometimes what exactly happens is we have to go for a valve replacement. I told that the favorable factors is not there. The indicating factors, that is no or mild MR, no LA clot. These are the factors which should be there, and the valve should be pliable, amenable to valvotomy. Then only you can take it up for a percutaneous mitral balloon valvotomy. If the valve is not amenable, then you can go for your valve replacement. There are two options. One is your mechanical or bioprosthetic valve. The bioprosthetic valve, the good thing is anticoagulation needed only for 3 months. Okay, so this is preferred especially in older age group individuals, more than 65 years of age. The life is less. When you put a bioprosthetic valve, the duration of the survival time of the valve is less. And so for elderly individuals whom anticoagulation may not be good for them, those people you can go ahead for a bioprosthetic valve. Whereas mechanical processes are indicated for all the patients less than 65 years, because if you put a bioprosthetic valve in them, the deterioration will be faster. The rate of deterioration will be faster, and they may not be benefited well. So you have to go for mechanical processes, and you should give lifelong anticoagulation for them. Okay, the target INR will be 3.5 to 4.5 if you replace the mitral valve. Okay, very important. So ideal treatment of choice is based on your valve status. Okay, based on your valve status, you will decide whether we are going for a percutaneous mitral balloon valvotomy or you want a surgery. Okay, so next topic we are going to mitral regurgitation. What is regurgitation? Regurgitation nothing but a leak. Okay, the valve is not closing properly. See this picture? This valve is not closing properly. So whatever blood is being pumped from here, entering into the aorta also and entering into this valve, because it is leaking, it is entering into the left atrium. Okay, so that will produce a classical murmur called as pan-systolic murmur. Since the valve leaflets are not coapting well, that will lead to a soft S1 pan-systolic murmur. Okay, sometimes S3 can be heard. Okay, large amount of blood coming down, again that can produce an S3. S3 occurs in the rapid filling phase, whereas S4 corresponds to your atrial contraction phase. Remember that? Yes. So what are the causes of mitral regurgitation? Mitral regurgitation can classify into acute MR and chronic MR. Acute mitral regurgitation happens in infective endocarditis, papillary muscle rupture, caudal rupture or blunt trauma. We discussed about the anatomy of the mitral valve leaflet. There is a caudate tendinate, there is a papillary muscle. Okay, and so these ruptures, okay, especially in patients with infective endocarditis, then you can go for a acute mitral regurgitation, and the presentation will be pulmonary edema. He presents with a sudden onset dyspnea, worsening dyspnea, okay, and with orthopnea. The patient will be very sick looking. Whereas chronic MR, it will be having an insidious presentation. There are three subsets: primary valve pathology, primary affecting leaflets or chordae, like a myxomatous degeneration, especially in a Barlow syndrome or mitral valve prolapse syndrome or rheumatic fever. These can lead to a valve degeneration. And secondary causes include dilated cardiomyopathy or ischemic cardiomyopathy. What happens is, when there is ischemia to the heart starts enlarging. So what happens? The annulus starts dilating. The mitral valve annulus is there, no? So that will start dilating. So that will lead to leakage of the blood from the left ventricle to the left atrium. Okay. And finally, annular calcification can produce mitral stenosis and mitral regurgitation as well. Okay. Other causes, connective tissue causes can also lead to mitral regurgitation, which include your rheumatoid arthritis, ankylosing spondylitis, okay, and systemic lupus erythematosus, Marfan syndrome. Okay, rheumatoid arthritis, ankylosing spondylitis, SLE, and Marfan syndrome. So these are the conditions also can cause mitral regurgitation. Understood? Okay. So what are the symptoms of mitral regurgitation? Acute MR presents with pulmonary edema, acute left heart failure features, which includes your dyspnea and orthopnea, whereas chronic severe MR can produce fatigue, exertional dyspnea and orthopnea and palpitation. So I have mentioned chronic severe MR. Okay, so mild or moderate MR may be asymptomatic only. Okay, and if pulmonary artery hypertension develops, then that will lead to your pulmonary artery hypertension symptoms, which include symptoms of RV failure. That is your ascites, edema. Okay, so these are the symptoms. So how will you say that the diagnosis is mitral regurgitation? So based on your clinical examination, you have to tell. So number one is systolic thrill palpable in the cardiac apex. That is one favorable point. In the apex beat will be shifted down and out and hyperdynamic in nature. Okay. And acute severe MR, there will be narrow pulse pressure and apex beat is not displayed. So these are the characteristic differences between the acute MR and chronic MR. Okay. Number one is the systolic thrill palpable in the apex. Number two is your apex beat displayed down and out. Okay. Next, coming to the auscultation. What are the characteristic points? S1 will be soft. Wide A to P2 will be there. This we discussed in the previous module. What happens is, the blood which is pumped from the left ventricle will have to go to the aorta only in a normal heart, but here there is leakage of the blood into the left atrium. So what happens is, there will be early closure of A2. As long as the blood flows through the aorta only, it will take some time for the aortic valve to close. It will wait for the blood flow to complete, then only the valve will close. Whereas here what happens is, there is leakage in another direction through the mitral valve. So the aortic valve will close early. Okay, that will lead to wide physiological splitting. Okay. The murmur classically is high pitched, slow blow, soft blowing, pan-systolic murmur. Any grade you can mention. Heard of the diaphragm of the stethoscope, left lateral position while the breath held in expiration, radiating to the axilla. So these are the classical points about the pan-systolic murmur of your mitral regurgitation. Okay, high pitched, soft blowing, pan-systolic murmur of grade 3/6, burst out with the diaphragm of the stethoscope in the left lateral position with the breath held in expiration, radiating to the axilla. So in this radiating to the axilla happens only if the AML is prolapsing more. Suppose there is an anterior mitral leaflet. Okay, if the anterior mitral leaflet is involved in the prolapse or the regurgitation, that will lead to your radiating to the axilla. The murmur radiates to the axilla. Whereas sometimes in some individuals, the posterior mitral leaflet will be prolapsing more, and that will lead to radiation of jet into the base of the heart. Okay, base of heart. Just a DD. Okay, if there is no radiation, what will you think? You can think that is posterior mitral leaflet prolapse. Okay, and there can be a short rumbling mid-diastolic murmur without a mitral stenosis. This I discussed already. If there is large amount of MR, there is severe MR, more amount of blood will enter into the left atrium during systole, and the same blood will come down during the diastole of the heart. That will produce your mid-diastolic murmur. Okay. And S3 can be heard in LV dysfunction. S4 can be heard in patients with acute mitral regurgitation. For S4 to be generated, you need no valve, no AV stenosis should be there. Atrium ventricular valve should be clean. There should not be any stenosis. That is very important. A good functioning left atrium is important. And another one is a non-compliant ventricle is very important. Okay. So acute MR only the S4 can happen, whereas chronic MR, what happens is the ventricle will go for an eccentric dilatation. Okay. So non-compliant ventricle will not be there. So the S3 is only generated. S4 is not generated in a patient with chronic MR. Okay. Okay. Basically, this is an early systolic murmur. Throughout the systole, if there is gradient, okay, especially in a patient with chronic mitral regurgitation, the left ventricle is enlarged, then the left atrium is enlarged. So what happens is the atrium will be able to receive the blood as long as the ventricle is pumping. Okay, so that leads to your pan-systolic murmur or holosystolic murmur. Whereas here what happens is the gradient will be attained early because the left atrium is small. Okay, it will not be able to accommodate the increasing blood which is pumped by the ventricle. Okay, so the murmur will be short. It will be confined to the early phase of systole only. Okay, so it is described clearly and correctly here, but this is wrong. Okay, so it is a early systolic murmur in acute MR, whereas pan-systolic murmur in chronic MR. Understood? Okay. Yes. So what are the symptoms of acute MR? It is sudden onset dyspnea, dyspnea and orthopnea, whereas here in chronic MR there is gradual symptoms. Apex beat is no change in acute MR, whereas it is down and out in chronic MR. Early systolic murmur in your acute MR and pan-systolic murmur in chronic MR. ECG shows sometimes normal, okay, because of the rupture. If any trauma is there, normal. Or MI leading to papillary muscle rupture, myocardial infarction leading to papillary muscle rupture, then the MI changes can be there in your ECG. And in chronic MR, there can be changes of left ventricular hypertrophy or left atrial enlargement or right atrial enlargement. Okay. So left ventricular hypertrophy can manifest with a strain pattern like ST depression in 1AVL V5 V6 with the T inversion. Whereas left atrial enlargement we discussed, it is your P mitral, right? It's a broad P wave which is seen in left atrial enlargement. Whereas right atrial enlargement will lead to P pulmonary, that is your tall P wave which is in your right atrial enlargement. And chest X-ray is normal in acute MR, whereas cardiomegaly can be seen in chronic MR. Understood? Yes. So this point what I discussed regarding the acute and chronic MR will again revise later stage, so that we will be having a constant knowledge. Since I told wrongly in the first part, I would like to revise it at a later part of this presentation. Okay. So what are the musical murmurs you know? Yes. One is your seagull or cooing dove murmur, okay, which happens because of the ruptured chordae tendineae in a patient with mitral regurgitation. Okay, this murmur can also be heard in aortic regurgitation as well. That will also be described here. And the flail leaflet can produce a murmur with musical quality. Okay, ruptured chordae tendineae, the murmur will be of cooing or seagull quality. And even AR, okay, then the aortic cusp is everting and vibrating in the flow, blood flow. Okay, what happens? The aortic cusp should be moving towards the blood flow, right? So when there is a systole, when there is blood is moving forwards, it will move forwards. But what happens in aortic regurgitation? The valve is not closing properly, so the aortic cusp will evert, okay, towards the ventricle during the diastole, and that can vibrate during the diastole. That will produce a cooing or musical diastolic murmur. Okay, so these are the causes of musical murmurs. This is also a favorite question for the examiner. Okay, so why pan-systolic murmur in MR? There is no closure of valves. So as soon as the ventricle starts contracting, there will be gradients. Okay, there will be difference of pressures between the left ventricle and the left atrium, and the blood flows from the left ventricle to the left atrium as soon as there is onset of the ventricular systole, and that leads to your pan-systolic murmur. Okay, so what are the differential diagnoses for pan-systolic murmurs? Yes, tell me. Mitral regurgitation, tricuspid regurgitation, ventricular septal defect, and one more differential diagnosis is your prosthetic valve leak. Okay, so these are the causes of pan-systolic murmur. The murmur is heard throughout the systole. The gradient is maintained throughout the systole. That leads to pan-systolic murmur. Okay, so apex beats in left ventricular hypertrophy versus right ventricular hypertrophy. It's very important question, very often asked by the examiners. Left ventricular hypertrophy can be of two reasons. One is your systolic volume overload or pressure overload. So volume overload can be due to your mitral regurgitation or aortic regurgitation or hypertonic circulation states that will lead to eccentric hypertrophy. So what happens is, this is the normal ventricle. Just imagine that this is the normal ventricle. What happens is there will be fibers arranging in this direction. Extra fibers will be arranging. Extra it will come. So what happens is it will be hugely dilated. Okay, and this will lead to down and out apical impulse. Okay, or the apex beat, down and out apex beat. Whereas what happens in your pressure overload is there will be concentric hypertrophy. So this is the normal ventricle. What happens is there is extra fibers coming like this. Okay, it will be parallelly arranged to the existing muscle fibers. So that will lead to, that is called concentric hypertrophy. This is called concentric hypertrophy chambers. So that will not lead to any change in the apex beat. Okay, remember this eccentric hypertrophy will lead to serial arrangement of your muscle fibers. That will lead to down and out apex beat. Okay, and right ventricular hypertrophy will lead to outwards, only moving of the apex beat outwards only in the same intercostal space. Okay, in the classical isolated mitral stenosis, this outward shift of the apex beat is seen, whereas when a patient with mitral stenosis having mitral regurgitation, then this is in down and out apex beat is seen. Okay, when do you say that mitral regurgitation is severe? Is there any specific findings which can tell you that, which can give you a clue that the mitral regurgitation is severe? Yes, there are points. Presence of systolic thrill over the apex. That is one. A large left ventricle which indicates severe MR. That means the apex is down and out. Okay, that can tell you that it's a severe MR. Presence of S3 can tell you it's a severe MR. And flow mitral mid-diastolic murmur. Okay, this has been discussed already. MDM is expected only in mitral stenosis, but it can also occur in mitral regurgitation if there is large volume of the blood which is entering into the left atrium and coming back to the ventricle during the diastole. Okay, understood? So what are the complications of MR? Once again, atrial fibrillation can occur, pulmonary hypertension can occur, infective endocarditis can occur. But remember that the infective endocarditis is more common in mitral regurgitation than in mitral stenosis. Whereas atrial fibrillation is more common in mitral stenosis more than mitral regurgitation. Okay, this is the difference. So how will you manage MR? Valve replacement is the management of choice. Symptomatic severe primary or secondary MR, you can go for a valve replacement. Asymptomatic patients, even when the EF is 30 to 60% or LV end systolic dimension is more than 4 cm. That means if the EF expected for a mitral regurgitation patient, okay, is more than 60%, ejection fraction is expected to be more than 60%. If there is slight decrease in the ejection fraction also, then you should consider valve replacement. That is telling that the ventricle is going for failure. That is one point. And another is the left ventricle end systolic dimension if it is more than 4 cm. So that also tells that the ventricle is going for dilatation and failure. Okay, end systolic, at the end of systole, what is the dimension? Is your 4 cm. Okay, if it is more than 4 cm, then you can tell that the patient needs a mitral valve replacement. Understood? So now I think we can recollect the point already discussed. Okay, so what happens in a patient with acute versus chronic MR? Okay, what is the difference? Acute versus chronic MR. Okay, especially with regard to the murmur. Okay, in chronic MR, okay, what happens? The left atrium is enlarged already and the left ventricle is enlarged already. Okay, so there will be constant gradient will be maintained. Okay, from the left ventricle to the left atrium. So that will lead to your pan-systolic murmur. Okay, whereas in acute MR, what happens is the left ventricle is small and the left atrium is small. Okay, and suddenly the valve is prolapsing into the left atrium. Okay, so the blood will not be the left atrium will not be able to accommodate all the blood which is be pushed by the left ventricle. So there will be earlier in your systolic phase there will be a gradient, agreed. Okay, even the late phase of the systole there can be gradient, but what happens is the left atrium will not be able to accommodate the increasing blood which is being received from the left ventricle. So there will be initially a systolic murmur, early systolic murmur, but it cannot last in the holosystolic fashion as with the chronic MR. Understood? Okay, there should not be any confusion with this, right? Then, mitral stenosis with mitral regurgitation, what is the dominant lesion? So, how can you identify? History-wise, predominant dyspnea favors a mitral stenosis, whereas a palpitation favors a mitral regurgitation. Okay, history-wise, dyspnea favors mitral stenosis and palpitation favors mitral regurgitation. Okay. Pulse will be low volume in mitral stenosis. Understood? It will be normal volume in mitral regurgitation. Okay. And apex beat will be tapping in your mitral stenosis, whereas it is hyperdynamic in your mitral regurgitation. How about S1? S1 is loud in mitral stenosis, whereas soft in mitral regurgitation. What about S3? S3 cannot be happening in the presence of a AV valve stenosis, right? So S3 can be heard in MR only, mitral regurgitation it can be heard. Okay, and opening snuff, a classical finding in your mitral stenosis. It cannot happen in mitral regurgitation. Mid-diastolic murmur can happen in both. Yes or no? Mid-diastolic murmur can happen in both. But what differentiates between mitral stenosis and mitral regurgitation? If there is pre-systolic accentuation, that suggests your mitral stenosis, whereas there will not be any pre-systolic accentuation, especially in a patient with mitral regurgitation. Okay, so I hope that this video will be very useful. So we discussed about the various important questions asked by the examiners. Okay, in a patient which you are presenting as a case of mitral stenosis or mitral regurgitation, you should be thorough with the findings. You should always be organized. You should be able to tell the findings right from the general examination to your auscultation in a continuous fashion. Okay, so that will earn confidence among the your examiner's mind, and that will tell the examiner that you have read properly, you are organized. Okay, and you have to know the mechanism of like all the things which we had discussed in the previous module. Okay, your examination, your pulse, your JVP, and murmurs, heart sounds, all these things should be thorough so that you will excel in the examinations. So with this we have come to the end of the module. Thank you one and all.